Good afternoon, everyone. Thank you for being here. Maybe I will just go through a brief introduction of today's webinar. And please let me know if you can see my screen. Ma'am, is it visible?
Yes, बिल्कुल.
All right, thank you so much. Okay, so today's webinar is called Navigating Treatment Options, Locating the Right Path to Recovery. So, why is it that we're doing this webinar? We have a series of 6 webinars that we have planned over the course of 4 to 5 months, and we hope to raise awareness for head and neck cancers and even for people like us who may not be suffering through the disease. It is extremely important that we are aware of what the true information is out there from credible sources, because head and neck cancer is something that is very, very prevalent, and we may never know when it might happen to us or someone close to us. We had the first webinar on 30th of November on just understanding what is head and neck cancer and what are certain symptoms to help aid its early detection. And today we are going to explore the different treatment options if we do detect head and neck cancer. Um, so today's speaker, Dr. Priya, she is a renowned medical oncologist. She's trained in dealing with all aspects of medical oncology and internal medicine. She is the head of medical oncology for Artemis Gurgaon. She has expertise in treating solid tissue malignancies, hematological malignancies, stem cell transplants. She's very well versed in administration of chemotherapy, hormonal therapy, targeted therapy, immunotherapy, and palliative care. She's a gold medalist, and she has published several papers in both international and national reputed journals. She's also a member of the American Society of Clinical Oncology, European Society of Medical Oncology, Immuno-Onco Society of India, etc. And her goal is to develop an oncology care model. So no one better than her to help us understand what is it that we need to do as informed patients to help our journey through head and neck cancers. And I will be sharing your presentation soon. Right away, ma'am. Give me a second.
So, good evening and sorry, good afternoon. Thank you for the kind word, Mugdha ji. So, it's always pleasure to talk about these topics pertaining to various aspects of cancer. क्योंकि like you said कि हाँ इस country में awareness कम है और बहुत ज़रूरत है. So I'm glad that you have started a series of lectures, and I'll be covering the treatment part. Yes, थोड़ा सा introduction भी लेंगे head and neck cancers के बारे में. So you can start sharing the screen, the presentation. So I'll try to keep the presentation short so that we have a lot of time for discussion, because I think yeah, it's very important that if you have any question that should be addressed. So please, हाँ. सो
Can you?
आई थिंक आप लोगों की ऑलरेडी एक क्लास हो चुकी है, इसके ऊपर एक सेशन हो चुका है,
Yes.
हेड एंड नेक कैंसर, व्हाट इज हेड एंड नेक कैंसर. सो इट्स सिंपली पुट एनी कैंसर ऑफ हेड एंड नेक रीजन. ओके, सो इसमें बहुत सारे पार्ट्स आते हैं, जैसे ओरल कैविटी आता है, लिप्स आता है, चीक आता है, गम्स आते हैं, टॉन्सिल्स आते हैं, फेरिंग्स आता है, फेरिंग्स के बाद लैरिंग्स आता है जो कि आपका वॉइस बॉक्स होता है, अपर पार्ट ऑफ फूड पाइप आता है जिसको कि हम सर्वाइकल ईसोफेगस बोलते हैं, एंड सलाइवरी ग्लैंड्स आते हैं जो कि सलाइवा बनाते हैं माउथ में. एंड यस ऑल्सो ये मुग्धा जी प्रेजेंटेशन विजिबल नहीं है.
Uh, I am sharing my screen. Just a second, I'll do it again.
मे बी वी कैन आस्क अदर लोग पीपल ऑल्सो इफ इट इज
Uh,
विजिबल.
is it visible now?
नो.
Um, just a second.
सो वेरियस पार्ट्स होते हैं. तो द इम्पोर्टेंट पार्ट अबाउट हेड एंड नेक इज दैट दो देर आर सर्टेन पार्ट्स, ये है कुछ सिमिलैरिटीज हैं मैनेजमेंट में और कुछ डिफरेंसेस हैं. इम्पोर्टेंटली ये बात पता है सबको कि द मेजर रिस्क फैक्टर इज टोबैको, एंड दैट्स द रीजन दैट इंडिया में ये कैंसर इतना कॉमन है, बिकॉज ऑफ द हैबिट ऑफ क्विट चूइंग. जो लोग पान तंबाकू मसाले खाते हैं, उसकी वजह से कैंसर इंडिया में बहुत कॉमन होता है. और इंडिया के जनरली हर पार्ट में ही कॉमन है. नॉर्थ ईस्ट में भी ये हैबिट्स हैं. आप ऊपर नॉर्थ में जाएंगे, वेस्ट में जाएंगे, साउथ में जाएंगे. India is the largest contributor of head and neck cancer to the world, and in men it is number one cancer in India. The unfortunate part about head and neck cancer is that it usually affects, a lot of patients are from the, this economically improvised sections. So the treatment becomes a challenge, and okay, usually the breadwinner of the family gets impacted by the disease. तो पूरे घर का इकोनॉमी हिल जाता है जब किसी भी पेशेंट को ऐसा कैंसर होता है. Can we ask other people? I think I'm not able to see the presentation. बाकी लोग देख सकते हैं.
From the audience, can you please let us know if you can see the presentation? I think someone has raised their hand. Um, Hi, Danya. Can you please unmute yourself? Hello. Am I with?
I can see the presentation. Yes, now I can see. Yes, you're
Yeah.
right.
All right.
Okay,
Thank
okay, yes. Is it it's visible? Okay. Yes, now I can also see.
you.
Thanks
All
for
right.
raising the hand.
One.
So, yes. So, the problem in the India is also the cancers. हम कहते हैं ना कि ओल्ड एज का प्रॉब्लम है. सारे
Yeah.
कैंसर्स ओल्ड एज में ज्यादा होते हैं, बट इंडिया में प्रॉब्लम ये है कि इंडिया में हम यंग पेशेंट्स बहुत, यंग लोग बहुत है, राइट. हमारे प्रेडोमिनेंट पॉपुलेशन हमारे यंग है, तो हम यंग में कैंसर्स बहुत देखते हैं. ऑल्सो ये जो टोबैको चुइंग, क्विट चुइंग की हैबिट्स होती हैं, और इवन स्मोकिंग होती है, ये ना स्कूल टाइम से ही लोग एक्वायर कर लेते हैं. तो चूंकि कार्सिनोजेंस को एक्सपोजर यंग एज से स्टार्ट हो जाता है, बहुत ही यंग एज से स्टार्ट हो जाता है, इसलिए कैंसर्स भी हम इंडिया में काफी यंग एज में देखते हैं. सो आई थिंक रिस्क फैक्टर्स आपको हेड एंड नेक कैंसर्स के पता ही होंगे. बिसाइड टोबैको एंड स्मोकिंग एंड दिस अल्कोहल, the other risk factor is poor oral hygiene. Yes, this is one of the cancers which can happen because of the poor oral hygiene. ऑल्सो अगर जैसे किसी के डेंचर्स खराब होते हैं, दांत खराब होते हैं, उनसे रिपीटेड टंग बाइट और ट्रॉमा होता रहता है, वहां पे भी एरियाज पे कैंसर बनता है. तो ना, जैसे ये एबनॉर्मल टूथ होते हैं, उनकी वजह से भी ये कैंसर्स होते हैं अगर वो रिपीटेड ट्रॉमा करते रहे टंग पे. अच्छा, इसके अलावा इसका एक और मेजर रिस्क फैक्टर जो कि अब आई थिंक आप लोगों को पता ही होगा, ह्यूमन पैपिलोमा वायरस है. ह्यूमन पैपिलोमा वायरस की इंडिया में कम बातें होती हैं, सर्विक्स कैंसर के केस के से रिलेटेड ज्यादा बातें होती हैं इसमें, है ना. बट वेस्ट में दिस हैज बिकम वन ऑफ द प्रेडोमिनेंट कॉज ऑफ हेड एंड नेक कैंसर्स, स्पेशली जो कैंसर्स इसमें होते हैं ना, ओरोफेरिंग्स. ओरोफेरिंग्स हमारे फेरिंग्स का एक हिस्सा होता है, उसके पार्ट को हम ओरोफेरिंग्स कहते हैं. दिस इज द प्रॉब्लम दैट एचपीवी एसोसिएटेड कैंसर्स आर नाउ इंक्रीजिंग. ओके. अच्छा, ये नॉन स्मोकर्स में भी हो सकते हैं, फीमेल्स में भी हो सकते हैं. इसीलिए आजकल गाइडलाइंस अब ये भी रिकमेंड कर रही हैं कि जो आप सर्वाइकल कैंसर वैक्सीन सुनते थे ना सर, एचपीवी वैक्सीन लोग सुनते थे, वो अब लोग कहते हैं कि यूनिवर्सली सबको रिकमेंड करना चाहिए, नॉट जस्ट फीमेल्स, है ना. क्योंकि हमें ये पता है कि एचपीवी की वजह से और भी कैंसर्स हो सकते हैं. एचपीवी की वजह से और कैंसर्स हो सकते हैं, इसलिए उनके प्रोटेक्शन के लिए सबको अगर हम वैक्सीनेट करेंगे तो एचपीवी का इन्फेक्शन ही नहीं होगा, और उससे होने वाले कैंसर्स नहीं होंगे. इसीलिए टू प्रिवेंट हेड एंड नेक कैंसर्स which is because of the HPV, these recommendations are being done. So what is important to know about head and neck cancers overall is the risk factors and the challenges. So like I said, the challenge in the India is that it affects the economically, sections which are, what we call as the poor sections, right. द लोअर सोशो इकोनॉमिक स्ट्रेटा. तो उनका ट्रीटमेंट वो हेल्थ केयर तक पहुंच जाए, वही बहुत बड़ी बात है. उनका टाइम से डायग्नोसिस हो जाए, वही बहुत बड़ी बात है. एंड टाइम से ट्रीटमेंट हो जाए, तब तो नथिंग लाइक दैट. ओके. एनी कैंसर कैन बी ट्रीटेड इफ डिटेक्टेड इन टाइम. दैट इज ट्रू. एंड बिकॉज ऑफ दिस रीजन ये हमारे यहाँ ना, एक तो हेल्थ केयर फैसिलिटीज नहीं है, ओवरवेल्म बहुत ज्यादा है हेल्थ केयर फैसिलिटी, क्योंकि पॉपुलेशन इतना ज्यादा है. और बिकॉज अवेयरनेस नहीं है, लोगों के अंदर नहीं है, उनको पता नहीं होता कि अगर माउथ में छाला बन गया हो, सोर बन गया हो, तो किसके पास जाना है. थैंकफुली अब क्या हो गया है ना कि देखिए, फर्स्ट पॉइंट ऑफ कांटेक्ट डेंटिस्ट एंड ईएनटी स्पेशलिस्ट होते हैं. किसी को भी माउथ में प्रॉब्लम होता है ना, तो या तो आप डेंटिस्ट के पास जाते हो या फिर आप ईएनटी स्पेशलिस्ट के पास जाते हो. तो एटलीस्ट अब उनके अंदर अवेयरनेस काफी हो गई है, जिसकी वजह से ये कैंसर्स ना, वो जैसे उनको कुछ भी लगता है, कोई भी नॉन हीलिंग अल्सर है ना, जो कि ठीक ही नहीं हो रहा है 1-2 महीने में, तो वो कहते हैं एक बार आप जाके ऑन्कोलॉजिस्ट से मिल लीजिए और एक इसकी बायोप्सी करवा लीजिए. सो ओवरऑल डायग्नोस्टिक डिलेज आर अ मेजर प्रॉब्लम. देखिए, जैसे मेडियन टोटल डिले ऑफ 73 days होता है फ्रॉम द ऑनसेट ऑफ दैट इज मोर देन 2 months. और देखो, इट्स नॉट लाइक लंग, ओरल कैविटी ऐसा होता है, और इवन हेड एंड नेक कैंसर ऐसे होते हैं ना कि टाइम से पता चल सकते हैं, क्योंकि सिम्टम्स सामने दिख जाते हैं, है ना. इट्स नॉट लाइक लंग कैंसर हो या गॉल ब्लैडर कैंसर हो, जो कि डीप सीटेड ऑर्गन्स हैं. ये ऐसे हिस्से हैं हमारे शरीर के ना, जो सामने दिख जाते हैं. फिर भी देखिए, 73 months ना, 73 days का डिले ना, इसमें बहुत ज्यादा मानते हैं हम. मतलब 3 weeks 4 weeks से ज्यादा डिले नहीं होना चाहिए. बट ओनली बिकॉज की इतना अवेयरनेस नहीं है, और हेल्थ केयर फैसिलिटीज भी स्ट्रीमलाइन नहीं है, सेंसिटाइज नहीं है, इसलिए ना काफी डिले होता है. नेक्स्ट स्लाइड प्लीज. अच्छा, दूसरा चैलेंज क्या होता है हेड एंड नेक कैंसर पेशेंट्स में? एक तो ये होता है कि चलिए कैंसर हो गया, कैंसर हो सकता है एडवांस स्टेज हो सकता है क्योरेबल कैंसर हो, कैंसर कुछ भी हो सकता है, राइट? कैसे भी स्टेज में हो सकता है एक्सटेंड में। प्रॉब्लम क्या होती है ना कि चूंकि पेशेंट स्मोक करते थे, टोबैको करते थे बहुत लंबे समय तक, चू किया ना, तो ये सारी की सारी सेल्स खराब हो जाती हैं। माउथ की खराब हो जाती हैं, गले की खराब हो जाती हैं, सलाइवरी ग्लैंड्स की खराब हो जाती हैं, हर ऑर्गन की ना उधर। तो वहां पे अगर आपने एक चीक की खराब हो जाती है, गम्स की खराब हो जाती है स्मोकिंग की वजह से। तो अगर एक कैंसर आपने ट्रीट कर भी दिया ना, तो हमेशा चांस होता है कि उन खराब सेल्स में दूसरा कैंसर हो जाएगा। ये ना बहुत ही एक यूनिक चैलेंज है हेड एंड नेक कैंसर पेशेंट में, जिसको हम कहते हैं सेकंड प्राइमरी कैंसर। सो अब यू नो अराउंड 10% ऑफ पेशेंट विल हैव अनदर प्राइमरी कैंसर। तो एक तो कैंसर का रिकरेंस का रिस्क तो होता ही होता है, बट बिकॉज वो जो एरिया है जिसको हम कहते हैं फील्ड ऑफ कैंसराइजेशन बोलते हैं हम, फील्ड ऑफ कैंसराइजेशन की वजह से ना वहां पे एक नया कैंसर बनने का रिस्क भी रहता है। तो एक ये बहुत ही ज्यादा चैलेंजिंग पार्ट हो जाता है हेड एंड नेक कैंसर पेशेंट्स में। अच्छा, इसीलिए हम ये कहते हैं कि जब भी कैंसर की डायग्नोसिस बने, इनको स्मोकिंग क्विट कर देनी चाहिए। क्योंकि अगर ये स्मोकिंग करते रहते हैं तो वैसे भी इनका ट्रीटमेंट टॉलरेंस भी खराब होता है, और ट्रीटमेंट के साइड इफेक्ट भी ज्यादा हो जाते हैं ऐसे लोगों में, और नए कैंसर्स भी डेवलप करने का रिस्क और भी ज्यादा बढ़ जाता है। नेक्स्ट स्लाइड प्लीज। So, like, I think you already know about this with the discussion in the last session that you had, that there are parts of oral cavity of head and neck cancers. जैसे कि एक माउथ का कैंसर हो गया, ओरल कैविटी कैंसर, जिसमें लिप है, टंग है, गम्स है, लाइनिंग ऑफ द माउथ है। फिर एक जो पीछे का हिस्सा होता है, जब आप swallow करते हैं, उस हिस्से को हम फेरिंग्स बोलते हैं, है ना? जो कि ये नोज एंड माउथ को लेके इसोफेगस या फूड पाइप तक लेके जाती है। फिर इसमें फेरेंजियल कैंसर्स में भी आता है, और अपर फूड पाइप का कैंसर भी साथ में ही लेते हैं, जिसको सर्वाइकल इसोफेगस या अपर फूड पाइप कहते हैं। फिर एक लैरिंक्स वॉइस बॉक्स का कैंसर हो गया, है ना? इसके अलावा फिर आपकी जो नेजल कैविटी और उनके अगल बगल जो साइनसेस होते हैं, उनका कैंसर होता है। सलाइवरी ग्लैंड कैंसर्स भी होते हैं माउथ में, जो आपके सलाइवा बनाते हैं। नेक्स्ट स्लाइड प्लीज। तो देखिए, सबसे पहले तो इंपॉर्टेंट बात यह है कि आप लोगों को सबके सिम्टम्स मोटे मोटे पता होने चाहिए, जिससे ये पता चल जाए कि पेशेंट को कब हमें रिफर करना चाहिए कि हाँ, कैंसर का पॉसिबिलिटी हो सकता है। ऐसा तो दुनिया भर की प्रॉब्लम्स हो सकती हैं, पर डिपेंडिंग अपॉन द साइट, किस साइट में कैंसर है वैसी साइट स्पेसिफिक सिम्टम होगा। जैसे कि अगर टंग में किसी को कैंसर हो रहा है, तो वहां पे क्या होगा ना कि एक घाव बन गया या नॉन हीलिंग अल्सर बन गया, ऐसा अल्सर बन गया जो कि हील ही नहीं कर रहा। जनरली क्या होता है ना, सबको माउथ में छाले तो किसी को भी हो सकते हैं, बट वो क्या होता है 10 दिन, 7 दिन, 5 दिन में ठीक हो जाते हैं, राइट? बट अगर माउथ सोर्स किसी को हो गए हो, है ना, और वो ठीक ही नहीं हो रहा, जैसे कि परसिस्टेंट अल्सर बोलते हैं कि 1 महीना हो गया, 2 महीना हो गया, हील ही नहीं हो रहा, और आपने कुछ एंटीबायोटिक दी, कुछ पेशेंट ने गार्गल्स कर लिए, और वो थोड़ा हल्का सा इंप्रूव करके वापस बढ़ गया। तो ये है ना, हमेशा एनी नॉन हीलिंग अल्सर्स बियॉन्ड 1 मंथ अगर माउथ में है किसी भी एरिया में, चाहे वो गम्स हो गए, चाहे वो चीक हो गया, चाहे वो टंग हो गया, सो दैट शुड ऑलवेज बी इन्वेस्टिगेटेड। इन्वेस्टिगेशन का मतलब है कि उसकी एक बायोप्सी या एक छोटा सा एफएनएसी यानी सुई डाल के एक सैंपल लेके एग्जामिन कर लेना चाहिए, डायरेक्ट ऑब्जर्वेशन अंडर द माइक्रोस्कोप, है ना? देन वी विल नो व्हाट एग्जैक्टली आर वी डीलिंग विथ, है ना? तो एक तो ये सिम्टम होता है। अच्छा, इसके अलावा क्या होता है, कई बार जैसे ये पेशेंट्स होते हैं जो ऑलरेडी स्मोक कर रहे होते हैं, इसमें ना क्या होता है कि कभी कभी एक व्हाइट पैच बनने लगता है, सेल्स में खराबी आनी शुरू करती है, तो एक व्हाइट पैच बन जाता है, जिसको हम ल्यूकोप्लेकिया बोलते हैं। तो ल्यूकोप्लेकिया हैज अ चांस ऑफ बिकमिंग कैंसर लेटर ऑन, है ना? तो कई बार ल्यूकोप्लेकिया भी अगर किसी में डेवलप हो जाए, तो उसको हमेशा जाके डॉक्टर को एक बार दिखा लेना चाहिए कि सर, कहीं हमारे जो ये पैच दिख रहा है, व्हाइट रंग का पैच दिख रहा है, इसमें कहीं कैंसर तो नहीं डेवलप हो गया। अच्छा, इसके अलावा क्या होता है ना कि जब भी माउथ के कैंसर्स होते हैं, वो हमेशा ना नेक में नोड्स भी क्रिएट कर देते हैं, नेक में ना नोड्स क्रिएट करते हैं। तो इस नेक में लिम्फ नोड की स्वेलिंग आ जाती है। तो किसी में आइसोलेटेड लिम्फ नोड हो गया, अब जैसे इन्फेक्शन में भी लिम्फ नोड नोड इनलार्जमेंट होता है, आप देखते होंगे बच्चों में इनलार्जमेंट होता है, हम कहते हैं टॉन्सिलर इनलार्जमेंट हो गया। टॉन्सिल्स भी एक तरह के लिम्फ नोड्स होते हैं। तो ये ना लिम्फ पर, वो जैसे इन्फेक्शन में भी इनलार्जमेंट होता है, तो वो 5-6 दिन में ठीक हो जाता है, राइट? बट सपोज करिए 2 वीक्स हो गए, 3 वीक्स हो गए, 4 वीक्स हो गए, और वो लिम्फ नोड की इनलार्जमेंट ठीक ही नहीं हो रही है ना? और जनरली कैंसर से एसोसिएटेड जो लिम्फ नोड इनलार्जमेंट होते हैं ना, ये सारे के सारे पेनलेस होते हैं। तो आपको जाके जरूर डॉक्टर को एक बार एग्जामिन करवा लेना चाहिए, है ना? अच्छा, इसके अलावा जैसे कि क्या होता है ना कि टंग के पिछले हिस्से में कैंसर हो सकता है, टंग के आगे हिस्से में कैंसर हुआ तो जैसे अल्सर हो गया। टंग के पिछले हिस्से में कैंसर हो सकता है, जो फूड पाइप का अपर हिस्सा है या फेरिंग्स का हिस्सा है, उसमें कैंसर हो गया। तो अगर कैंसर यानी कि ग्रोथ हो गई, राइट? ग्रोथ होगी तो खाना पास नहीं कर पाएगा, तो पेशेंट को हम बोलते हैं डिस्फेजिया स्टार्ट हो जाएगा, कि खाना नहीं घोट पा रहा, रोटी नहीं खा पा रहा, पानी तो चलो फिर भी पी लेता है, बट उसमें क्या होगा ना कि गांठ बन जाने की वजह से ऑब्स्ट्रक्शन डेवलप हो जाता है। और कभी कभी अल्सर्स कैंसर की वजह से, अल्सर जैसे माउथ में बन सकते हैं, वैसे ही फूड पाइप में भी बन सकते हैं, फैरिंग्स में बन सकते हैं। तो वहां पे पेशेंट को दर्द भी हो सकता है तब, है ना? सो इम्पोर्टेंटली और क्या होता है, जैसे लैरिंक्स का, अगर किसी को वॉइस बॉक्स का कैंसर हो गया, तो क्या होता है, होर्सनेस शुरू हो जाती है। तो जैसे कि आप सबका जैसे बरसात में गला खराब हो गया, तो नहीं, गला बैठ जाता है, बट फिर वो 3 दिन में रिकवर कर जाता है, राइट? बट वो वॉइस चेंज रिकवर ही ना करे और 7 दिन, 15 दिन, 2 हफ्ते, 3 हफ्ते चलता जाए, तो हमेशा एक बार डॉक्टर से ना वो डायरेक्ट का फिर हम कहते हैं कि यार ये वॉइस बॉक्स का एग्जामिनेशन करवा लो, उसमें कोई और प्रॉब्लम तो नहीं है। अच्छा, जैसे वॉइस बॉक्स में चेंजेस के और भी प्रॉब्लम हो सकती है, कभी कभी इन्फेक्शन भी हो जाते हैं, लॉन्ग टीबी हो जाता है, बट हमेशा एक बार एग्जामिन कर लेना चाहिए, है ना? तो अब ये है, अब जैसे कि सलाइवा बनाने वाले ग्लैंड्स में अगर हो जाता है कैंसर होता है, तो उसमें अगेन स्वेलिंग प्रेजेंट होती है, चीक में स्वेलिंग हो जाती है ना, माउथ में स्वेलिंग हो जाती है। तो ऐसी कोई भी स्वेलिंग डेवलप हो जाए तो आपको एक बार डॉक्टर से जाकर जरूर चेकअप करवा लेना चाहिए। नेक्स्ट स्लाइड प्लीज। तो देखिए, किसी भी कैंसर का ना, हेड एंड नेक कैंसर का या फॉर दैट मैटर एनी भी, किसी भी शरीर में कोई भी कैंसर है किसी भी हिस्से में, तो उसका मैनेजमेंट इस बात पे डिपेंड करता है कि कैंसर एग्जैक्टली है कहाँ, राइट? देखिए, जैसे कि टंग है, अगर टंग में छोटा सा कैंसर हुआ तो वो तो सर्जरी करके निकाल सकते हैं। हेड एंड नेक में सबसे बड़ा चैलेंज ये होता है ना कि हर साइट में आप कैंसर की सर्जरी नहीं कर सकते, इतना कॉम्प्लिकेटेड एनाटॉमी है ना हेड एंड नेक स्ट्रक्चर का, जैसे कि तो हर बार ना मेजर सर्जरी पॉसिबल नहीं हो पाती है। तो अगर जहां सर्जरी पॉसिबल नहीं हो पाती है वहां हम कोशिश करते हैं कि हम रेडिएशन की रेस देके ट्यूमर को जला दें, है ना? तो हेड एंड नेक कैंसर में हमेशा ना मेजर सर्जरी, क्योंकि हम देखिए कैंसर्स में क्या होता है ना कि हमें हमेशा सेफ मार्जिन चाहिए होता है। कैंसर की सर्जरीज जो होती है ना, इन्फेक्शन की सर्जरीज नहीं होती हैं। इन्फेक्शन में क्या होता है कि आपने चलो बस थोड़ा सा सफाई कर दी वहां पे तो इन्फेक्शन ठीक हो गया, राइट? पर कैंसर में ना हमें एडिक्वेट मार्जिन लेना होता है। अगर हम मार्जिन नहीं लेंगे तो कैंसर में रूट्स होती है और वहां से वापस ग्रो कर जाएगा, है ना? तो कैंसर की सर्जरी हमेशा ज्यादा रेडिकल होती है और मेजर होती है। तो हेड एंड नेक में ना कई बार क्योंकि एनाटॉमी ऐसा है कि बहुत स्ट्रक्चर्स पे ना हम पॉसिबल ही नहीं हो पाता है कि हम प्रॉपर सर्जरी कर पाए, प्रॉपर मार्जिन ले पाए, इसलिए रेडिएशन भी बहुत साइट पे यूज करता है। इसलिए मैनेजमेंट इस बात पे निर्भर करता है कि पेशेंट को एग्जैक्टली कैंसर है कहाँ। अच्छा, दूसरा इस बात पे भी निर्भर करता है कि साथ में कोई और प्रॉब्लम तो नहीं है। जैसे कई बार पेशेंट को डायबिटीज हो सकता है, बहुत ब्लड शुगर कंट्रोल नहीं हो रहा है, तो सर्जरी में डिफिकल्टी आएगी। एज बहुत ज्यादा है, कैंसर जैसे 80 साल में हो गया, 90 साल में हो गया, तो फिर आप सोचेंगे कि भाई ये ट्रीटमेंट भी टॉलरेट कर पाएगा कि नहीं। किसी को अगर हार्ट ही काम नहीं कर रहा, तो ये सारे फंक्शंस भी हम देखते हैं कि साथ में कोई और दिक्कत तो नहीं है पेशेंट को। क्योंकि कई बार जैसे पेशेंट अगर स्मोक कर रहे होते हैं तो इनके बहुत सारे ऑर्गन्स कॉम्प्रोमाइज रहते हैं, इनको हार्ट में भी प्रॉब्लम हो सकती है, इनका ब्लड प्रेशर भी ज्यादा होता है ना, इनको हो सकता है हमें स्ट्रोक की भी हिस्ट्री मिल जाए। अच्छा, इसके अलावा एक्सटेंट ऑफ डिजीज इज वेरी इंपॉर्टेंट किसी भी कैंसर में, राइट? छोटी सी गांठ है तो फिर भी आपने ट्रीटमेंट कर लिया, पर अगर बड़ी गांठ है तो फिर आपको देखना है कि पहले हमें साइज छोटा करना है ट्रीटमेंट इलाज करके, उसके बाद ही हम कुछ ना कुछ वो कर पाएंगे, इलाज कर पाएंगे। तो एक्सटेंट ऑफ डिजीज यानी कि लोकल डिजीज कितना है और कहीं बीमारी शरीर में फैली हुई तो नहीं है। कैंसर्स का प्रॉब्लम क्या होता है ना कि एक जगह से वो कई जगह जाती है। अगर वो कई जगह जाएगी तो इसको मेटास्टेटिक डिजीज कहते हैं, है ना? तो मेटास्टेटिक डिजीज जो है ये प्रॉब्लम होता है और इसीलिए हम एक्सटेंट ऑफ डिजीज देखना बहुत इंपॉर्टेंट है। तो एक जगह है बीमारी और कितनी है, जैसे सपोज करिए 1 सेंटीमीटर की गांठ है या 5 सेंटीमीटर की गांठ है, राइट? तो ये देखना भी बहुत जरूरी है। जस्ट तो एक जगह है या मतलब छोटी सी गांठ है या बड़ी गांठ है। अच्छा, जैसे मैंने आपको बताया कि गर्दन में लिम्फ नोड्स में गई है कि नहीं, है ना? गर्दन में लिम्फ नोड ये देखना जरूरी होता है, क्योंकि हम देखिए चक्कर क्या होता है ना, लिम्फ नोड्स के बारे में आप सबको ये बात जाननी जरूरी है। हर ऑर्गन जो भी हमारे बॉडी में होता है ना, हर उसके बगल में ना कुछ लिम्फ नोड नाम के स्ट्रक्चर्स होते हैं। ये हर ऑर्गन के पास होते हैं, चाहे लंग्स हो गए, चाहे फीमेल्स में ब्रेस्ट हो गया, मेल्स में ब्रेस्ट में भी होते हैं, चाहे प्रोस्टेट हो गया, आपका इंटेस्टाइन हो गया। इनका काम ये होता है ना कि इम्यूनिटी को रेगुलेट करते हैं, ये ब्लड फ्लो को रेगुलेट करते हैं, बहुत इंपॉर्टेंट और इंटीग्रल स्ट्रक्चर्स होते हैं। और कहीं से कैंसर जब शुरू होता है ना, तो सबसे पहले जैसे कि सपोज करिए किसी को टंग में कैंसर हुआ, तो उसके बाद जो उसके बगल में लिम्फ नोड होगा उसमें जाएगा। तो हमें ये भी ख्याल रखना है कि हमें ये पता होता है कि लिम्फ नोड में कैंसर की जाने की टेंडेंसी होती है, तो इसलिए हम साथ में वो लिम्फ नोड्स भी रिमूव करते हैं। तो इसीलिए कैंसर का मैनेजमेंट, हेड एंड नेक कैंसर का मैनेजमेंट इस बात पर निर्भर करता है कि पेशेंट को एक तो बीमारी कहाँ है, बीमारी कितनी है, और साथ में मरीज की बाकी हालत शरीर की कैसी है। एंड दिस अप्लाइज टू एक्चुअली एनी कैंसर्स, बट मोर सो फॉर हेड एंड नेक कैंसर्स। नेक्स्ट स्लाइड प्लीज।
Ma'am, sorry for the interruption. We seem to have quite a few international people who have joined the webinar. So if we can just switch to English, that would be great.
Okay. So I think till now it is okay, or should I just
No,
revise?
no, it's okay, ma'am. I suppose we can take it.
Okay. So I'll just continue in English then.
All right.
Yes.
Thank you so much.
So like I previously said, any cancer is diagnosed on the basis of, so you suspect it on the basis of symptoms, okay? Like I said that you have any non-healing ulcers in the mouth or any change in voice, any lymph nodal swelling which is persisting beyond 3 weeks or 4 weeks, okay? Then we know that this could be a possibility of being cancer, and so it should be investigated. So what you do is like if you have this suspicion that this person can have a cancer, then we send them for a biopsy sample. There are various ways to do a biopsy. The ENT surgeon can take a biopsy, or sometimes the ultrasound radiologist, a radiologist can simply see the swelling under the ultrasound and take a sample. A cancer is never diagnosed without getting a biopsy or at least an FNAC. FNACs mean put in a small needle and take a sample. Okay, so and you should never treat a head and neck cancer without a biopsy or FNAC. Okay, sometimes people fear that if it's a very common misconception that if you do a biopsy, the cancer will spread, which is not right. Okay, it does not spread. The head and neck cancers, they don't spread by doing a biopsy. So biopsy or FNAC is an integral part of the diagnosis of cancer. And after that, we do a scan to see the extent of disease. So you also do a clinical examination, but yes, you do a scan. So people will do a CT scan, a PET scan whole body to see if the cancer has migrated to other organs or not. Cancers have a very high tendency to go in the blood and then go in the other parts of the body. Head and neck cancers, they can, go to the lungs. They have a very high tendency to go to the lungs. So we always do a chest imaging is a must for a cancer patient, head and neck cancer patients. So once we find out that what is the local extent, we do a CT or maybe MRI sometimes of the local site. And in addition, we do a chest imaging. And sometimes we can also do a whole body PET scan. That will help us to decide what is the extent of disease. After getting the complete information regarding the diagnosis and extent of disease and evaluating the general condition of patient, then only we decide the treatment of the patient. Let's go to the next slide. See, the important thing is why do we want to see the extent? Because it not only helps to tell us what could be the particular treatment option, but we also know that with the increasing extent of the disease, the survival are poor. Just to give you a few figures, if you have we divide the head and neck cancers in 4 stages, 1, 2, 3, 4. The 4 have a very dismal outcomes. Okay, even stage 3 patients, 30% chance of recurrence is there. So because these cancers become so extensive that, even after treatment, few cells will be left here and there, and from there the cancers will grow again. This is the best outcomes you have with stage 1 disease. Stage 1 is a very small lesion, and it's just limited to the organ from where it has started. There are no local lymph nodal mets. It's a very small disease, and hence the more than 90% of patients will do very well. Next slide, please. So MDT means multidisciplinary meetings. So team meetings. See, what we understand is that now no cancer is just treated by one department. You have a medical oncologist, you have a radiation oncologist, you have a surgical oncologist, you have a pathologist, and you have a radiologist. So everybody will sit down and decide what is the best management. Also, because what is happening now, see, a lot of updates are coming. Like a surgeon can tell you that what is the surgery update. Maybe this patient for 10 years back, this is a kind of disease which the techniques were not available to operate, but now we know that this kind of lesions can now be operated with improvement in techniques. So that is why everybody sits down and they give their expert opinion, and then a line of management for the patient is decided. For head and neck, it is very important because it is a site of disease where sometimes you need to do chemotherapies to decrease the tumor size, followed by surgery or radiation. So a multidisciplinary tumor board meeting is a must for head and neck cancer patient. Also, what happens in head and neck cancer patient is not just that the cure that we are looking, because head and neck, even patient can have a lot of morbidity. Sometimes the surgeries could be major and it can just involve a lot of reconstructions, and sometimes patient can get like a disfigurement. So it's very important that we find ways to decrease those kind of long-term side effects also. Suppose a major surgery will lead to a major disfigurement, though the patient will be cured. Okay, so if we can do some chemotherapies to shrink the tumor and then do a surgery so that the disfigurement part can also be taken care of. Okay, so all these things are discussed in a multidisciplinary tumor board meeting. Okay, so next slide, please. So these are the treatment options that are all available, that patients can be given options of surgery, and we'll discuss that which are the patients who are fit for what. How do we decide? So surgery, radiation. So like I said, the main challenge in the head and neck cancer patients, sometimes the patient, with surgery, it is not possible to remove the complete lesion and get a proper adequate like 1 centimeter margin. So, we can just burn these tumors. So radiation works very nice. So radiation means using lasers or simply rays to burn the tumor cells, and it works wonderfully, and the outcomes are as good as surgery for many other sites where surgery is not possible. Also for certain tumors, for like the tumors of the voice box. So suppose if the patient has developed cancer in the voice box, if there is cancer in the voice box, if you do the surgery to remove the cancer, that the voice will be gone forever, which becomes a big morbidity for the patient, isn't it? So now the techniques have come that at the place of doing a surgery, you can just do radiation to burn the tumor. So the voice may not be again like it was normal, but yes, some kind of functionality will be retained. Okay, it is very much possible to preserve the voice with the use of radiation therapy for tumors of the voice box. So even if it is possible to do a surgery, we know that because we want to preserve the organ of the function of the organ, we will give them the benefit of radiation therapy. So radiation has substituted surgery in many in many organs where we see that if the functionality will be compromised because of the surgery, so we can do radiation in those tumors. Then you also have options of chemotherapy, and we see how the role of chemotherapy is actually coming up in head and neck cancer patients. Now, the latest talk of the town is immunotherapies, and you also have target therapies. A very important role of dietitian and nutritional counseling in head and neck cancer patients. See what happens now. Most of these tumors will actually affect the mouth, the upper part of the neck. So patients are not able to eat properly. They will have pain while eating. So they are nutritionally compromised. So it's very important that these patients should always be given a nutritional counseling, how to eat, what to avoid, the frequency of meal, the high protein diet, high calorie rich diets, and it should be constantly assessed. See what happens when you are nutritionally deprived, the treatment tolerance will also suffer, isn't it? Your treatment tolerance will also go down. You'll have more side effects. You will take longer time to recover, isn't it? So your chance of cure will also decrease. So it's very important that the nutrition part should always be taken care of, especially the head and neck cancer patients. Next slide, please. So like I said that, so what has happened now is that you have a dedicated head and neck cancer. So cancer surgeries have evolved. It's not just the one person who is operating everywhere. You have a head and neck cancer patient, you have a head and neck surgeon, you have a lung cancer surgeon, you have this ovarian cancer surgeon. So, very site-specific cancer managements have come. So it has become micro-specialization. It's also leading to development of excellent expertise. So now good centers have a dedicated head and neck surgeon. Okay, and they sit down in a MDT and then we decide. So it is like I said, important thing is whether surgery is possible and what could be the reconstruction, and yes, what would be the morbidity involved. Like I said, that sometimes chemotherapy is given before surgery. So one of the role of chemotherapy is that it is to shrink the tumor. Okay, so it helps to achieve the down. Suppose if there is a big tongue ulcer, which is cancerous, okay, the surgeon will say that if I remove the tongue, you can't live. The problem with removing the tongue is both the speech as well as the food intake will be compromised. So if the surgeon says that you give some chemotherapy, the size of the lesion will decrease. Okay, then it will be possible for the patient to maintain his some quality of life. Okay, and of course, some part of the tongue will be removed, but yes, it will be better than what will be the plan initially. Okay. For certain areas, we know that the margins will be very easy to take, like if there is a cancer. So surgery is the preferred option. Like if the cancer is of the lip, if cancer is of the cheek, if the cancer is of the gums, and anterior part of the tongue, they are easy to remove and reconstruct. So surgery is preferred over radiation therapy. Like I also said, you can also burn the tumor. Okay, you can do the radiation therapies. But here, these are the sites where it's possible to do surgeries, remove, take the adequate proper margin, do the proper reconstructions. So for these sites, the surgery of this surgery is preferred. For certain sites like a voice box, surgery might not be preferred, but it's still an option. It's also for sinuses. Surgery is an option. For these sinuses tumors, maxillary sinus, it is an option. Okay. But sometimes, yes, we know that when you take the surgical specimen and when it goes to the lab for proper examination, we know that what exactly is the tumor extent. And maybe after that, we can also calculate that what could be the risk of recurrence. And if I feel that if after the surgery, the risk of recurrence could be high, then I might give patient radiation therapies and chemotherapy also. Now, one of the question is that why am I giving radiation therapy after surgery? The tumor is gone. See what happens. Like I said, that the cancer can have roots, and if I feel that the surgical specimen had lot of tumor, like suppose stage 3 disease, I know that there will be few roots which will be left here and there. So I want to burn these roots using radiation therapy. Okay, so most of the times also, if you want to remove the cancer in totality, the margin should be free. There should not be any tumor touching the margin. But if you find, oh, in the surgical specimen there was a margin positive, I know that from there it can come back. So I need to do this radiation therapy. And sometimes to improve the function, the penetration of radiation, we give this patient benefit of chemotherapy also. So these are the important points about the surgery. Maybe go to the next slide. So radiation therapy, like I said, so this is one of the very old modalities. I think people don't know much about radiation, but this is one of the old modalities. So before surgery, actually, at many centers, people started using radiation to kill cancer cells. And once the radiation therapy started being used, the cancer killing, especially head and neck cancer, showed remarkable improvement. One of the problem is that with radiation is that again lot of side effects can happen. People think that it's that surgery has most of the side effects in head and neck cancer, but it is not like that. Sometimes radiation can have also lot of side effects, mouth sores, etc. Especially people who continue to smoke. See, the problem with the smoking is that it decreases the blood supply of the organs. Now, if the blood supply is of any organ is compromised, we know that the oxygen will be compromised. Oxygen won't go to the organ, the nutrition won't go reach the organ. So any ulcer or any problem happening, any side effects is happening, the healing will be compromised, isn't it? So that is a problem with so radiation shows sometimes can have a lot of toxicity in these group of patients. But yes, radiation is a very good treatment option. It has shown results as good as surgery for many sites, like for voice box cancer. And for certain sites where surgery is not possible because it's not possible to take a proper clear margin to do a major surgery or reconstruction, radiation is a preferred approach. Like posterior part of the tongue, base of the tongue, oropharynx, nasopharynx, so these are the sites where we prefer doing radiation to burn the tumor. Radiation is not given in a single day. It is given in a small amount, usually every day, and it can go up to 7 weeks. So a small amount of radiation every day. So it's a long treatment. And sometimes to improve the penetration of radiation therapy, we also do chemotherapy. Next slide, please. So see, this is how we decided. We sit down in MDT. Everybody sits down, and we see what could be the best possible management. So suppose, like I showed you certain examples of the site where surgery is possible. Certain sites where radiation will be preferred. Okay. So we sit down and see, okay, what was the site of the disease? What is the extent of the disease? And yes, if the patient has any other comorbidity or not, which can impact his treatment tolerance. So if there is a small lesion at any area, easily amenable to surgery, such as lip, cheek, gum, etc., we do surgery. Okay. And then we send that surgical specimen to the lab to decide if the patient requires any post-operative treatment or not. Okay, such as chemotherapy, radiation therapy, or chemoradiation. But if there is a large lesion, which the surgeons feel, oh, I won't be, there will be a lot of problems, lot of morbidity after surgeries, then the chemotherapy will be given to decrease the tumor size, and then subsequently patient undergoes surgery. These patients who are always given chemotherapy before surgery, they usually are given chemoradiation also after surgery, because we know that these tumors will have a very high chance of recurrences. Okay, and if the tumor is at a site where surgery is not feasible, then we do, okay, radiation oncologist, you go forward. And to increase the penetration of radiation, we do, let's give some chemotherapy. So people don't know this, that chemotherapy actually improves the efficacy of radiation therapy. So what are chemotherapies? Chemotherapies are the cells, are the medicines which kill the cancer cells. Okay, this could be mostly injectable formulations, but yes, there are oral chemotherapies also available. Okay, but yes, if the scan show, oh, this is a metastatic cancer, this cancer has already gone in the lungs, or if the patient condition is so bad that he won't be able to tolerate either surgery, radiation, then what we do, we say, okay, let's try to just control the cancer for as long as possible. And then here it becomes the aim of the treatment is palliative. The aim of the treatment is just to control the symptoms of the patient as long as possible to prolong his life, but not cure. And here we just give them some chemotherapies, some immunotherapies, and target therapies, or some tablets, what is called as metronomic therapies. Next slide, please. So just an example of chemoradiation. Okay, so we heard about surgery, we heard about radiation. So chemo and radiation are sometimes given concurrently. So like I said, radiation is given daily. In these patients, chemotherapy will be given either once a week or once in 3 weeks. This improves the penetration of radiation. Okay, but at the same time, it will also because the efficacy is more, so the side effects are also more. Okay, it goes hand in hand. So these patients have more mouth ulcers. These patients will show longer time to recovery, and sometimes could be long-term side effects in deficits in speech and swallowing. Next slide, please. So I think we discussed the long-term complications. If you do radiation, it can cause thyroid dysfunctions, and there could be impact on saliva formation. So head and neck cancer patients have a lot of dryness in the mouth, or they keep complaining that we are not able to eat bread and chapati. That requires a lot of saliva formulation. But the way to beat it, that we have certain drugs which helps to improve the saliva formation. Okay, next slide, please. So we were talking about now the systemic therapy. So we touched upon the surgery, radiation, but now the systemic therapy, like I have been just very briefly touching about chemotherapies. So like chemotherapies, I told you one role was there before surgery. Sometimes you give it after surgery also to decrease the chance of recurrence. You give it in combination to radiation, what is called as chemoradiation. But for the patient who have advanced or spread out cancers, we know that you just cannot treat every site of the disease. Okay. So you just try to, so you cannot use surgery or radiation in those patients. You can just do some kind of treatment, so that there is any treatment which goes in the blood and controls all the sites of the disease for as long as possible. And that is where the chemotherapy comes in. Next slide, please. So these are the terms that I have been telling you about, the immunotherapy and target therapy. So we have to know the difference between the three. Chemotherapy is something which will kill the cancer cells. It will just go to a cancer cell, see if the rate of multiplication is high. The cancer cells, they keep multiplying. So chemotherapy will work on the rapidly multiplying cells, and it will kill it. Okay. There is another kind of treatment called as target therapies, which is like a very new term. The target therapy has to do nothing with the rate of multiplication. It will kill a cell which expresses a particular target. Okay, so it's just like that there is a door and which has a lock, and it's like a key. Okay, so it will just open it, the key fits in the lock, open the door, and kills the whatever is there inside that room. It will just kill it. Okay, and then you have an immunotherapy. So the advantage of target therapy is they are more specific and they have lesser side effects compared to chemotherapy. And you also have something called as immunotherapy. Immunotherapy has a lesser side effects again compared to chemotherapy. They improve a particular body immunity. They stimulate a particular body immunity cells, which actually kill the cancer cells. And these have improved the outcomes of stage 4 cancer cells across many other cancers, including head and neck cancers. Next slide, please. So these are the common terms, common names: paclitaxel, docetaxel, methotrexate, cisplatinum. Cisplatinum or the carboplatinum are the most effective chemotherapy drugs in head and neck cancer. Next slide, please. And the immunotherapy drugs are pembro, nivo. So suppose if the patient who comes, so when we have done a staging workup and we realize, oh, this is an advanced cancer patient, this cannot be given benefit of surgery or radiation. Then we decide, okay, what should be the systemic therapy? Okay, let me give you at least some treatment to control your cancer growth, isn't it? So I will tell, okay, I will start with chemotherapy, but at the same time, I will see if I can give you addition of immunotherapy or target therapy also or not. So I just showed you names of certain chemotherapy drugs. So we usually use a combination of one of those chemotherapy drugs, like Pacli, cisplatin, something like that. But then we will also do certain tests on the biopsy sample, which will tell me whether the immunotherapy will work also or not. Okay, and which is like the PDL1. And there are certain tests which will tell me if the target therapy will work or not. Okay, so I start the patient on chemotherapy, but on the biopsy I'll put certain tests which will also tell me what is the treatment in addition to chemotherapy that I should add to maximize the chance of benefit and improve his control duration of the disease and achieve the maximum symptomatic relief. So PDL1 is one such test. So whenever a head and neck cancer patient comes, we will see the extent of the disease. And if we see if the patient does not qualify for a local treatment such as surgery and radiation and has the patient advanced disease, then we will treat the patient using chemotherapies plus minus immunotherapy or plus minus target therapies. Next slide, please. So these are the example of pembrolizumab and the nivolumab, and the target therapies are cetuximab, nimotuzumab, and there are tablets of target therapy, gefitinib, erlotinib, and afatinib. Next slide, please. So I think that's all. If there are any questions, I'll be happy to take. And because I thought that it might just get too complicated, so we'll start with the questions and see if they, I need to clarify the certain other aspects.
We did have someone asking about childhood cancers. If you may shed some light on that, ma'am.
So just a minute. So the childhood cancers means rhabdomyosarcoma is the common cancer affecting children. The childhood cancers affecting head and neck cancers are childhood cancer anyways are rare. Head and neck cancers in childhood are again very rare. But one such cancers that is commonly affected is either lymphoma. Like in Africa, the lymphomas are very common. The other cancer is rhabdomyosarcoma. Rhabdomyosarcoma is a kind of sarcoma. Sarcoma means something, the cells like the muscle cells, tumor originating. Now, or see, the thing is, RMS has a very good outcomes if detected in time, especially head and neck RMS or rhabdomyosarcoma. Now, the problem is that if the cancers are not detected in time, again, they can spread and cause a lot of problems. And like I said, that head and neck cancer patients, head and neck rhabdomyosarcomas, again, are usually at the site where the surgery is not possible. So radiation and chemotherapies are used for the treatment. The rhabdomyosarcomas could be of embryonal or alveolar subtype. The embryonal are the most common and they have the best outcomes, and they are treated with a combination of chemotherapy and radiation, and they show very good outcomes provided they have a limited disease. So they can affect the nasal part, paranasal part, maxillary sinuses. All those are the areas where we see childhood cancers. We don't see tongue cancers in kids. We don't see voice box cancer in kids. Okay, the cancers in the kids are different compared to the cancer in the adults. So that is about the childhood cancers.
The way age sort of determines what type of cancer you may get, because, like you said, some children are not prone to getting tongue cancer and all. Does age and gender also affect the treatment, the efficiency of treatment or the choice of treatment?
So see, the thing is this, na, that what happens, the age, the kind of cancer is the most important. Suppose, like I said, that I'm mentioning a term called as rhabdomyosarcoma. Now, rhabdomyosarcoma, whether occurring in the adult or occurring in the children, will be managed on the similar line. Provided that the adult is not very old, like if rarely it can also happen in an 80-year-old. 80-year-old person won't be able to tolerate a proper treatment, isn't it? But usually they are managed on the similar lines, provided the histology is same. Also see, the problem is if patients who are very young have a different kind of complications, long-term complications compared to adults. Okay. For us, we know that see, radiation, one of the long-term complication that they can later in the life, they can develop secondary cancers related to radiation. Okay, so it's very important that sometimes we'll prefer that if there's a modality which does not require radiation, if there's a treatment modality, if the cancer is away at the site, so I will prefer that. Or if I can avoid radiation to cure the cancers, if I can do that, I prefer that. Okay, so radiation have a more longer time side effects in kids compare of secondary cancers compared to adults.
Right. Perhaps you can also help us understand if genetics plays a role, because we know genetics, they are very prevalent when it comes to cancer occurrence in a patient. Like if you have a history, then you're more prone to it. Does it affect the treatment in any way?
So head and neck cancers are mostly not related to genetics actually. Head and neck cancers are mostly because of the increasing age. They are mostly because of the risk factors. See, for the pediatric cancers, like I said about the rhabdomyosarcomas, we still don't know what are the exact risk factors. We might contribute that to the some environmental exposures during pregnancy, but most of them are actually not related to this any particular addiction, pediatric cancers. And adult cancers are mostly because of either because of the age or because you see increasing any cancer is common with the increasing age, and we see because of the risk factors, but most of the adult cancers or head and neck cancers are not because of a genetic component.
You have talked about quite a lot of types of therapies. Are these options limited by a person's ability to fund these treatments? Like, how would a limited budget determine the choice of treatment for a patient?
See, that is the biggest important question, isn't it? Most important question. If the patient can afford the treatment, so you
Yeah,
decide the treatment, you decide the patient needs a surgery, right? But if the cost of surgery is something which the patient is not able to afford, what will you do?
yeah,
What will the patient do, isn't it? So
yes,
the cost, of course, becomes. See, in India, a lot of patients they don't have their insurance. In India, patients they, out of the pocket expenditure, and like I said, that they have this problem that it affects the poor social economic condition patient, isn't it?
yes.
So yes, the treatment is actually decided. The cost becomes an important deciding factor that what should be the treatment. I'm talking about the drugs called as immunotherapies. Immunotherapies are the patented drugs. So most it's like the just like three or four companies which are manufacturing it across the world, and they are very costly. Though the companies have now started giving some assistance, but majority of Indian patients are actually not able to afford these drugs. So, like in India, suppose you have this system that you have a government setup where the treatment is at very, very, very minimal cost. Okay, but the problem is that they are overwhelmed, isn't it? There are just too many patients there. So, if they go to the private sectors, again, they're not able to afford. We understand the how the private sector model works. Okay, so they're not able to afford the treatment. So yes, at the end of the day, the cost becomes a very important deciding factor in the treatment, and cost of not only the treatment of the supportive care, isn't it? Suppose if you want to employ some a caretaker to take care of somebody who is a cancer patient, suppose you're a caregiver and you work in an office, and you want to employ a caretaker for your mother who is undergoing treatment, isn't it? So that amount of financial toxicity is also important. At the same time toxicity of the treatment becomes important, isn't it? Like we have a lot of international patients in Artemis. Okay, for radiation they have to stay for 7 weeks, 8 weeks. Okay, so the time that they are spending on the treatment also needs to be looked at. Okay, the time they spend from coming, going, and for stage 4 cancer patients, for the stage 4 cancer patient, the survival is not more than 2 or 3 years. But the patient has to come to the OPD, sit down, take the treatment, chemotherapies in daycare. Somebody has to accompany that patient. So it's also a burden over the time. So time toxicity, financial toxicity, everything becomes deciding factor in patient treatment decision. Yes.
If you were to just tell us briefly as to which type of treatment would be most expensive, just a ballpark assessment, like if someone does have the finances and they want to choose not what is most efficient, but understand what is most expensive, then how would you be able to rate them?
No, no. See, the thing is, this. Suppose if I were to talk, so this is a very much a cancer site specific topic. See, if I were to tell you that if the patient has a cancer in the cheek, okay, suppose I'm talking about the cancer of the cheek. So I said that okay, the patient has to undergo surgery, and after that the patient will require maybe chemotherapy and also radiation therapy. Okay, so this treatment will be completed. A good quality treatment at a good center will be completed in 10 lakhs max. 10 lakhs or maybe 7 lakhs. Surgery will cost around 3 to 4 lakhs. Radiation will cost additional around 2.5 to 3 lakhs, and 1 lakh will cover for the chemotherapy. Most of the time, we might not require surgery and radiation post surgery, but I'm just giving you an example. Okay, one might not require radiation. So this is a very much a side specific. But suppose if somebody who has a stage 4 cancer, where I'm talking about immunotherapy and target therapy. So suppose if I do a test and I tell you that this immunotherapy is going to work in addition to the chemotherapy, but then the cost of 1 year of treatment will be easily around 15 to 16 lakh of rupees. And the second year will be so much. So 2 years of treatment cost will be around 30 lakhs. So this is I'm talking about the best possible treatment. Okay.
Yes, ma'am.
But the best possible treatment also might not be able to achieve cure in a patient who has, I know that it can improve the survivals over something which is cheaper. But at the same time, I know it's not going to cure the patient completely. For a stage 4 cancer patients, when you are giving them a high cost treatment, the expectation of the patient will also increase, isn't it? They said,
Yes.
I'm shedding so much money, I should get cured, isn't it? And I should have less of side effect. But
Yes,
in stage 4, I will just say, oh, this is just going to prolong your life for some months. It's not going to cure it. Okay, so that is not what the patient wants to hear. But this is what it is. So,
right?
what I would suggest, what I would tell you, a curative treatment is usually completed between 10 to 12 lakhs in a good center. A good high volume, a nice center which takes care of everything, which provides you all kinds of active, supportive care. So, if you're talking about a curative setup treatment like radiation, surgery, and post-op treatment, it is usually covered between 10 to 12 lakhs. But for the metastatic cancer patients, the cost of treatment escalates like anything because the treatment has to go on, go on, go on, and not every treatment option is cheap. The immunotherapies, target therapies are costly.
Right. So, ma'am, I suppose to summarize, what we can say is that there is no definitive cause that can be attached to this disease
Yes,
because
yes.
the progression of the cancer and the type of treatment that you're taking, how long do you have to take the treatment for? Are there any extra therapies that you need to take along with the main treatment?
See, the
Or
thing is this, no, I would suggest everybody to take a proper insurance.
yeah,
It's very important that people should have an insurance, okay? Because sometimes there are centers which are offering good treatment, but they are very expensive. Okay, so that is why in India the problem is now we have to do a lot of adjustment because they don't have money, they don't have insurance. People who are earning also well, they don't have this awareness.
yeah,
So it's very important that everybody should have an insurance. That is first and foremost thing. The
yes,
second thing is that yes, the important thing is that if you can vaccinate both males and females for HPV. Okay, now we are starting the HPV vaccination for females as young as we say 9 years. And in Western countries, they are also saying that everybody should get vaccinated. So, even I agree because HPV related cancers are now increasing.
ma'am.
And
So, ma'am, we talked about how targeted therapies and genomic therapies are something that are available for treatment. Can you
yes.
can you tell us how these also play a role when we talk about vaccines? Why are there different vaccines? Why do some countries like Russia have vaccines and can those be sort of remade in India? The same
So
technology?
the vaccination that Russia has talked about has yet not been shown any effect in the clinical trials. It's a very preliminary work that they are talking about. See, I tell you what. So there are two kinds of vaccines. The one is the HPV vaccine. Okay. So HPV vaccine, what it does is that you give a vaccine to somebody who has not been exposed to HPV infection. What the vaccine will do that it will generate an immunity in the body so that if the HPV virus comes, that particular immunity kills that HPV virus. And if the HPV virus infection won't persist in your body, you won't have any cancers because of the HPV. That is a simple vaccination, funda of vaccination. Okay. Now, the vaccination that Russia is talking about, and which is again a different concept of cancer vaccine, says it's altogether a different field. It tells us that what you can do is that there are certain kinds of viruses, certain kind of particles that I can tag with a particular cancer-related protein, and that I can introduce inside the person's body. That will stimulate a particular immunity, which is going to kill the cancer cells. Now, this is a very new and a very appealing concept, but like I said, it's a very new. So it has yet not been tried properly in the trials to show the efficacy. So like there is a lot of excitement, and some they see some kind of that some signal of some benefit in some preclinical models, and they say, oh, it is going to work. But until and unless it does not show an impact in the human body in a major trial, we don't recommend that. So the vaccination that Russia is talking about is that kind of cell vaccine. But it is like going to take a lot of time to actually show the benefit in the clinical trial before people start recommending it.
Yeah.
And a lot of countries are doing that kind of work. It's then the US, it's then in the India, it's in the European countries. Most of the countries are doing the work on these cell vaccines or cancer vaccines. So it's different from HPV vaccine.
Ma'am, now that we understand that vaccines are really important as a preventive measure, especially when we know that cancer can happen to anyone. But talking a bit more about what is it that we can do from our end as a consumer to make the life of a physician or anyone who is giving us treatment a bit better. Can we prep ourselves in any way before the treatment to become better, to make the treatment more effective for ourselves or for a loved one?
See, treatment more effective is different than the vaccines, isn't it? See, the problem is the social media or the print media or the mass media, they have to talk about vaccines. So, when this incident of Poonam, that actress Poonam Pandey happened, isn't it? One day she claimed that she had cervical cancer. So everybody started talking about the HPV vaccine. So when the media takes up this aspect of the vaccination, I think everybody will get educated. People don't even know. They don't know that there is a vaccine. They don't know where the vaccine is available. The most of the common question we get, madam, क्या आप वैक्सीन लिख दोगे? मैडम ये वैक्सीन मिलती कहाँ है? अच्छा मैडम वैक्सीन का कोई साइड इफेक्ट? People just don't know about it because they don't know from where to get the education. So if the media starts to talk about, it's just like in between their news or in between their social media, if they just run one slide, okay. So like if they're influencers, if the influencers will just run one slide in between their platforms, their videos. Okay, this is so important. And Australia is a country which actually eliminated a cervical cancer thanks to these vaccinations. So that is one aspect of it. Now, telling about how to decrease the cost of the treatment. The cost of the treatment can only be reduced if the treatment is diagnosed in a stage where it is in a very early or the infancy stage. Okay. See, more is the disease, more will be the treatment, and costlier it will be. It is a very simple understanding. Okay, very simple concept. So, like I said, when you have a very small lesion, you can remove it by surgery. If there's a large lesion, you do chemotherapy before surgery, you also do radiation after surgery. Okay, so then the treatment will increase, and then the cost will increase. So you have to detect the cancer in time. So what is the important thing? We know that these head and neck cancers happen mostly in the smokers, tobacco chewers. So if we can just have a screening program, okay, see what happens if somebody is above the age of 30 years, okay? If we decide that, okay, once a year, this person, we will go to the community, we will screen their mouths and their throat for the cancer. Just imagine the impact that we'll create, isn't it?
Yes.
So screening is the best method, and head and neck cancers can be easily screened. You open the mouth, you examine the throat. They're very easy to screen, and we know that the most common risk factor is smoking, tobacco chewing. So you go to a suppose you go to a basti, you go to a community. You say who are the smokers, who are the tobacco chewers, what is your age? We want to examine you, and you find out. See, when you do the screening does not cost much. Okay, they are the simple examination tools. That is the best way to decrease the treatment cost, to detect the cancer in early stage. Okay. See, you can also devise various methods to help the patient bear the cost of the treatment. Okay. Or you can negotiate the cost with the government. You can negotiate the cost with the companies to give the special cost of the immunotherapy, chemotherapies. Okay. But any sustainable method will be the head and neck screening to take it in a big way.
Absolutely, ma'am. All right. We're just a few minutes away from the end of the session. So if anyone has any other question, please put them in the chat. And ma'am, we have a question. Is there any role of physiotherapy for head and neck cancer?
Oh, yes, a lot. Physiotherapy is important and must for all the cancers and also for head and neck cancer patients. See, what happens now in head and neck cancer patients? Suppose if they are, sometimes if I talk about, if suppose somebody was taking smoking, tobacco, pan, what it impacts now, it causes lot of scarring of their muscles, which are very important for chewing purpose. And sometimes when they do surgery, the same kind of problems happen, that the mouth is not able to adequately open. So there are physiotherapy which will tell you how to improve the mouth opening. Suppose if the mouth opening is very narrow, you're not able to eat food, okay? So that you just sit on liquid sips of water. So physiotherapy helps to improve the mouth opening in these cancers. Sometimes, if the cancer is impacted the posterior part of the mouth and you have done radiation, then what happens now? The mechanism which is very responsible for swallowing, deglutition also gets impacted. So there are physiotherapy exercises which will tell you how to improve the swallowing and deglutition. Also, sometimes we have, because sometimes you become very weak, you become bedridden. So and then arms and upper limb, the lower limb physiotherapy should be given so that the muscle does not become weak. So every head and neck cancer patient should always be at least once should go to a dietitian, should once at least go to a physiotherapist. And there are dedicated physiotherapists to take care of head and neck region, like the swallow therapist, speech therapist. Okay, so they'll take care of those needs.
Right. I do have a single question, perhaps. Why is the
I think
government
we missed, why not?
Well, that's a question. I think it's beyond the scope of our
No,
webinar.
no. See, the simple reason is because government is earning money because of them, isn't it? The government is the
Uh,
government is earning money because of it, isn't it?
That's true. Well, I think to bring the topic a bit back to the main agenda of the discussion, I have one last question, ma'am. We have been hearing a lot about genomics being sort of the future of treatment. We have CAR T
Yes.
therapy, and we have all these CRISPR-Cas9s and everything coming up. Do you believe it is something that is going to become an essential feature?
Oh yes, yes,
For
yes. So see, what I'll tell you, the optimist as well as the realist in me, the cancer is not going to get managed the way it is being managed today in next 10 years. For the simple reason is that we are not getting the tools and the technologies which can actually tell me the info. See, cancer is a very much, so we understand that the cancer is smoking related, but at the same time we have to understand that no two cancer patients are same. Cancer is a very different biology in one patient and a very different biology in the second patient. Now, what we do right now, we are treating them as the similar, same patients, same disease biology. Okay, this is the cancer, you have head and neck cancer, this is the histology, we'll give you chemo radiation. What the genomic is going to tell me that it is going to give me a tailored treatment option. See, like I already know that the HPV related cancers have a better prognosis. I know that the PDL1 positive cancer patient do better with immunotherapies. So that is the kind of information that I want to take. And the down the line, this is what we are going to get. We are going to get the tools in the form of genes with the help of artificial intelligence, how to analyze the data so that it can give me a very tailored, a patient specific treatment. It can tell me, okay, this patient will do so good on immunotherapy that I can avoid surgery in this patient. If this patient is going to do so well on just by surgery that the patient does not require radiation, even though the other markers will tell you that the radiation is needed after surgery. So yes, genomics are going to come in a big way in all the cancers, and head and neck cancer is not going to be an exception.
Right. Thank you everyone for joining us today. Thank you, Dr. Priya, for this really, really informative session. And you talked about everything in such a simple manner, and it's really helpful for people like us who are not from a very technical background. I was not anticipating such an overwhelming engagement from the crowd, especially the international one. So thank you everyone for making this session so interactive. And yeah, have a great day, everyone.
Okay, so I think that will be all. We can wrap it up. Thank you.
That will be all. Thank you, everyone. Thank you, ma'am. Have a great day.